Our third presentation, our third moderator for our third presentation, please, Dr. Zeina Al-Maani is a consultant endocrinologist, will be our third moderator. Thank you.
Thank you to the Palestinian Society for organizing this successful conference. It would be my pleasure now to present our next speaker, Professor Francesco Schiarelli. Professor Schiarelli is the head of pediatric at the Department of Pediatrics, University of Chieti in Italy, and he is there also the head of research labs at the research center. His research interests include the molecular and cellular biology of diabetic macroangiopathy, growth and insulin resistance in children, early detection of diabetes microangiopathy in children, obesity, and type 2 diabetes in children. He has written extensively and been published in leading scientific journals. And these include 645 papers and over 14,000 citations. I will stop here for the sake of time and present to you Professor Schiarelli, where he will be talking to us about vascular complications in children with type 1 diabetes. Please, Professor.
Thank you very much. Okay, thank you. So thank you very much indeed for inviting me to this conference. I'm very honored to be here tonight. And I'm a pediatrician, so we'll go back to children, to childhood, if I can. So actually this is my disclosure. I'm now working with the European Commission and the WHO on non-communicable diseases in children, which actually is where we have to act if we really want to prevent cardiovascular disorders later in life. You know, you may be aware that in some places in the world, the prevalence of obesity is in children is around 30 to 35%, which means that in 40 years, these children will be adults and will be adults with cardiovascular and metabolic complications. This is my summary, and no problems. Thank you very much. I will briefly mention the burden of diabetes throughout life, starting in childhood, and then about the complications of diabetes, the cardiovascular complications with the focus actually on nephropathy, on kidney failure, and on retinopathy in children. And what is very important in the next future is to understand better the pathogenesis, as Professor De Fronzo just mentioned, the pathogenesis of nephropathy starting in childhood in order to have new biomarkers and to try to understand very early in the course of diabetes who are the children who eventually will develop complications. So you heard already that complications of diabetes, you know, everybody knows that the diabetic kidney disease is still the leading cause of end-stage renal disease, as retinopathy is in fact the leading cause of blindness in working-age adults, and as you heard already, diabetic neuropathy and cardiovascular diseases are very frequently. So if you may be persuaded that children are not at risk for developing vascular complications, you are definitely wrong. This is a large epidemiological study showing that if you have diabetes early in childhood, the risk of death is very high later in life, and you actually lose 18 years of your life. So children with diabetes are those at major risk of developing complications because of the disease. So again, and the same is true during puberty, and puberty is in fact one of the major risk factors for later complications of diabetes. And this is also in late adolescence. So as pediatricians, we must be aware that the complications are starting very early in life. So therefore, we have to struggle to have the best metabolic control from the very beginning of the disease and to try to understand, as I said very early, who are the children who eventually will develop complications. This is quite a recent paper by Loredana Marcovecchio, who is now in Cambridge with a group of David Danger, who summarized the development and progression of vascular complications in childhood onset type 1 diabetes. And you can see actually that the early signs of vascular complications may be already present early in childhood, like with increased urinary albumin excretion rate and microalbuminuria. I will discuss briefly how to define microalbuminuria, which is still one of the risk factors for later development of nephropathy. And also hyperfiltration, because hyperfiltration, again, could be considered one of the major risk factors. And I will show you some data on increased pulse wave velocity and impaired endothelial dysfunction and abnormal retinal vascular geography. So again, we have to try to understand very early in the course of diabetes which are the risk factors for later development of late hard outcomes like proliferative retinopathy, proteinuria and end-stage renal disease, diabetic neuropathy, cardiovascular events, and eventually death, as we already heard. So the risk factors for diabetes complications are many of them. You can see here summarized some of them. Of course, what I want to stress here is that for diabetes complications in children, insulin resistance play a role already in childhood. And because we have many children with obesity, as I said, and also injecting insulin peripherally makes children insulin resistant by definition. And obviously, as Professor De Fronzo just stated, genetics is very important. So we take care of children with diabetes, and we have to ask if there is a strong familial history for cardiovascular disorders, cardiovascular disease, and then also, as we heard, diabetic kidney disease, because this is considered one of the risk factors for later development of the complications. As pediatricians and pediatric endocrinologists, we have been interested in the role of growth factors. IGF-1, for instance, has receptors in the kidney, so therefore studying the growth hormone IGF-1 axis may add some information on the risk of developing complications. Obviously, hyperglycemia and high blood pressure are the part of the ominous octet, as we just heard. And inflammation, general inflammation is some of, I will show you some data on that inflammation may play a role in the complications of diabetes. Starting with the nephropathy, obviously for many years, Giancarlo Viberti and other groups around the world has demonstrated that microalbuminuria is in fact one of the first signs of diabetic nephropathy. Why we are still used microalbuminuria after almost 40 years when the first paper was published on Lancet by Giancarlo Viberti, because that study was one of the few longitudinal studies showing that if a person has an increased albumin excretion rate, namely more than 20 microgram per minute or more than 30 milligram for 24 hours, or they have an albumin creatinine ratio more than 2.5 milligram per millimolar, these people are at major risk of developing kidney disease. But the very point that I want to raise tonight is that we actually have to understand better the biomarkers early in the course of diabetic kidney disease in order to detect these children either in stage 2 or in stage 1. So the definition of microalbuminuria has been recently revised in the ISPAD guidelines published on pediatric diabetes last year. And I want just to concentrate on the fact that if you want to have a reliable marker. You have to collect the spot, the early spot, the early morning urine samples in order to detect the children at risk for having microalbuminuria. So here in this cartoon, you can see how microalbuminuria can develop during childhood and puberty. And I want to show you here that you have, this green is the persistent microalbuminuria. To define a persistent microalbuminuria, you have to have an albumin-creatinine ratio more than 2.5 milligram per millimole in 2 out of 3 collections in early morning samples. And obviously, you can have a child approaching puberty, which is over the microalbuminuria cutoff point, and this child can develop actually persistent microalbuminuria, never goes back. But you can also have a child who can have transient microalbuminuria, which means that the child has microalbuminuria just during puberty, because puberty, for several reasons, worse metabolic control, hormones, testosterone, estrogens, which can have an action on the kidney particularly, but also on the retina. The child can develop transient during puberty, and then after puberty, the microalbuminuria may be normal for several years, but inevitably, later in life, the meaning of transient microalbuminuria, and also the so-called intermittent microalbuminuria, which is also quite frequent during puberty, these people can be considered at risk for later development of diabetic nephropathy. So we have actually to change our mind in some way and to understand that even those children who have so-called normal microalbuminuria, albumin excretion rate in the normal range, but in the third tertile of the normal range, could be at risk of developing kidney disease later in life. Obviously, the DCCT, as you may know, is now published from almost 30 years, demonstrated that obviously the risk of complications is related to metabolic control. Let me state a couple of things. This is the general DCCT study, but you can see also that even in the adolescent cohort, the results were similar. Just to stress a couple of things here, is that obviously very poor control, even if you reduce control of 1% of HbA1c, you can actually reduce the relative risk substantially. So every effort must be done to improve metabolic control. Let me say from the very beginning of the disease, which is quite an important issue related to education of the family and the child and the adolescents in order to keep the metabolic control good, as good as possible. In fact, if we look at the HbA1c in relation to age, actually the results of this longitudinal study was quite disappointing. You can see here the mean HbA1c related to age, and you can see that both in childhood and particularly during adolescence, the quality of care, the quality of control of diabetes is quite poor. And to reach the aim of around 70.7, you have to wait until the age of 30, which is inevitably too late in order to prevent diabetes complications. So we have actually to act very early in the course of diabetes in order to reach the best control possible from the very beginning of the disease. Another point that I want to raise here is that even if you have the same HbA1c, your risk of developing complications may vary. Why? Because if you have two children, one with the HbA1c 8%, so reasonable control for childhood and adolescence, and another child with the same HbA1c but less variability, this child, I guess, this child will be the yellow one, will be at major risk of developing complications. So the new concept of having the glycemia in time and range as close as possible to normal is an important issue. And with the continuous glucose monitoring, we can actually follow these children more carefully in order to detect those with better control, particularly with variability. If you don't trust me, there are several studies showing that variability of glucose control is one of the major risk factors for later development of complications. This is a study done by in Cambridge again. You can see that the intrapersonal SD or serially measured HbA1c, defining HbA1c variability, is actually related to microalbuminuria, to a major risk of microalbuminuria. So avoiding HbA1c glucose variability as soon as possible and as best as possible is an important point to prevent complications in children. And there are other studies. This is a study coming from the Sydney cohort, from the Kim Donahue group, again showing that in a prospective cohort study from 1990 to 2014, and you can see that the quartiles of SD HbA1c were actually related of the prevalence of microvascular complications, namely albuminuria, retinopathy, and interestingly, in children, also cardiac autonomic neuropathy. So there is quite a strong evidence that HbA1c variability and the glucose variability is one of the risk factors for microvascular complications in children. So what about molecular aspects of this field? Just let me show you, this is the AGE, the advanced glycation end products receptor. Obviously, we use an advanced glycated end products every day in our life, and this advanced glycated end products is named HbA1c actually. But let me show you also that angiotensin II is able, as the AGE through the receptor, and angiotensin II through its receptor, to evoke a cascade of inflammatory actions that they are quite important in the developing of nephropathy. Many years ago now, we show that in children and adolescents with type 1 diabetes, advanced glycation end products were actually higher in soluble ages, were actually higher even in small children. And later, there was a paper published quite recently coming from a Danish group showing that the formation of serum AGEs starts very early in the course of diabetes. And if we presume that advanced glycated end products are a risk factor for developing of nephropathy, we should try to prevent advanced glycation end product. You can see here that the carboxymethyldecene and pentosidine were actually related to HbA1c. So when we have HbA1c quite high, the advanced glycation end products is very active. So how can we try to prevent this? And why some people with very high HbA1c, there are data coming from the Joslin Clinic in Boston showing that there are some patients who actually have quite poor control and will never develop complications later in life, and other people who have reasonable control that actually they develop complications. Why? Obviously, there is a genetic predisposition, as we already heard, to diabetic nephropathy and cardiovascular complications, of course. So we tried to understand, for instance, the receptor for the AGE, if this can help us to understand. You know, the receptor of the AGEs is obviously in many tissues, for instance, in the kidney, in the heart, in the muscles, and obviously, if you have a good receptor for the AGEs, obviously the AGEs, the advanced glycated end products, act very, very, very quickly and very hardly. So the point is that there is a receptor circulating, endogenous secretory receptor for the AGEs, which is circulating in the blood, and it is actually a scavenger for the advanced glycations. In other words, if you have a good soluble receptor for the AGEs, you can catch the AGEs in the blood, and therefore the AGEs can act less in the kidney and in the retina. So we tried in a prospective study together with the group of David Danger. These are children followed in the UK and in Italy, and you can see here, so it is actually a prospective study from around 1,000 children from the diagnosis, followed from the diagnosis. So this graph shows that these are people who actually, children who actually developed microalbuminuria later in life. We followed them for almost 20 years. And you can see here that from the very beginning of the disease and before the development of microalbuminuria, the endogenous secretory receptor for the AGEs was lower compared to those who actually did not develop microalbuminuria. So we concluded that study and the paper stating that from the very beginning, the reduction of the endogenous secretory receptor for the AGEs could be one of the markers for later development, of, at least of microalbuminuria. Obviously, this field has been developed further, and you can see here one of the papers which were published detecting the urinary cytokine-chemokine signature of renal hyperfiltration in adolescents, actually, with type 1 diabetes. To cut a long story short, these new biomarkers are mainly related to inflammation. Obviously, Professor De Fronson and Mohammed, they know quite well CD40 ligand for the reason that CD40 ligand was used in some studies for cardiovascular risk. In other words, the higher is CD40 ligand, the more is the risk for later development of myocardial infarction. So, and there are other markers, for instance, MDC is a marker of the kidney. So again, to cut a long story short, the message is that the more hyperfiltration you have, the black bars here, the more you activate inflammation. So inflammatory markers could be used for early detection of diabetic nephropathy in children. So another field of interest for evaluating risk biomarkers for later risk of development of complications is the microRNA. Is also quite an interesting field. There are several studies, I don't want to be too long here, showing there is a relation between some microRNA and diabetic complications. This is a paper showing that the microRNA 125B and the increased of microRNA 146A, 5P, blunts NF-kappa B, which, as you may know, is a signal for inflammation. So therefore, microRNA could help to identify these patients at risk for developing diabetic nephropathy. And also non-coding RNA and diabetic nephropathy is an interesting field of research. This is a paper coming also from our group to showing that this microRNA could promote the diabetic nephropathy, at least in the animals. So do we have then new biomarkers for diabetic nephropathy in children? Obviously, we have to concentrate on biomarkers of glomerular damage. I'm very glad that Professor De Fronson underlined the fact that the the nephropathy from the very beginning is also a tubular disease. So we neglected, I think, this point in the last decades. But as I will show you, there are some interesting biomarkers of tubular damage that could be used for detecting of children at risk for developing complications. And I will briefly go through these 4 biomarkers of diabetic nephropathy in children. So these are biomarkers of diabetic nephropathy, namely the 4 glomerular markers. Transferrin, for instance, has been used in some studies. Transferrin has the same molecular weight of albumin, so it's not surprising that can be used as a glomerular markers. But as I said, quite interestingly, there are new studies showing that some interesting tubular markers, NGAL or KIM or NAG, could help us to understand children at risk for developing complications, namely nephropathy, and also markers of oxidative stress and inflammation, as I said, could help. So again, to cut a long story short, you can, if you are able to measure all these biomarkers, you can actually correlate these biomarkers with the risk of developing nephropathy in children. And in the future, these biomarkers could actually help us to understand early in the course of diabetes which children are, and adolescents, patients in general, are at the major risk of developing nephropathy. So the International Society for Pediatric and Adolescent Diabetes stated recently, when we have to start screening for nephropathy in children, you can read yourself, we should start actually 11 years, at the age of 11 years, with 2 5 years of diabetes duration. And let me say that unfortunately, we have to still use urinary albumin-creatinine ratio, because actually we do need longitudinal studies to, as I said, understand exactly which biomarkers we could use for later development of complication. Let me state that probably the tubular biomarkers and the inflammation biomarkers could help and the hyperfiltration to understand children at the major risk of complications. Obviously, evaluation and control of hyperglycemia, as I said, from the very beginning of the disease, control blood pressure in children, which is also very important as blood pressure, as glucose control, and try to treat lipid abnormalities early in the course of diabetes. They are quite frequent also in children, so we have to screen children for lipid abnormalities. So briefly, I want to just to mention retinopathy, because it's obviously also in pediatrics is an important complications. Everybody knows the fundal images of diabetic retinopathy. Just I want to state that quite recently, I have to say, the Danish group showed that retinal vascular geometry may be used for prediction of long-term microvascular complications. In other words, if you have different retinal vascular geometry, you can predict not only proliferative diabetic retinopathy, but also you can predict diabetic nephropathy and diabetic neuropathy. So studying the geometry of retinal vascular is more important than just having an ophthalmologist evaluation close to you with just the retinal fundal image. So evaluating new markers also for the retina may be important to detect the children at risk for developing retinopathy and microvascular complications. So again, the retinopathy, still the same as nephropathy, 11 years, start at 11 years with 2 5 years diabetes duration. Unfortunately, again, we just have a fundal photography. I should say just fundal photography, because don't trust the ophthalmologists, because as the nephrologists, they don't understand diabetic retinopathy. So, and therefore, you must have a fundal image in order to compare during the course of diabetes. And again, the same risk factors here are important, and particularly for retinopathy, control of high blood pressure in children with diabetes is very important, and also to keep the weight lower. This is for all complications, but particularly for retinopathy and macrovascular complications. So ladies and gentlemen, I hope that I persuaded you that the risk for vascular complications is high in young patients with diabetes. So we pediatricians must control these children very carefully from the very beginning of the disease. And because there are now strong studies showing, strong epidemiological studies showing that if the diabetes starts in childhood, the risk of death is much higher than later in life. You lose around 20 years of life because of diabetes in childhood. Obviously, the pathogenesis of vascular complications is complex. We have to study further, and therefore, if we in the future will understand better the pathogenesis of vascular complications in children, we could actually enable the identification of early markers. We desperately need early markers for complications in children. And obviously we can, I didn't have time to speak about treatment, but actually we can individualize and tailor the treatment for these complications also in children. So thank you very much for your attention.
قديش بدك لتشبك؟
جاهز بس اشبك هدول.